Good morning, everyone, and welcome to the World Orphan Drug Congress in USA 2020, a virtual event. I'm calling in from France. We have a team in the USA based in US Central Time. We have members of the team in the UK and other parts of Europe as well as Barcelona. They all welcome you. Happy to welcome you from wherever you're dialing in. And we are going to be talking about what Volv Global does in terms of data science, or AI as people call it, to help diagnose patients with diseases, rare diseases, much earlier in the disease cycle. We're not just going to be talking about successes, but we're also going to be talking about some of the challenges, because we think those are going to be very interesting for you. Overcoming these challenges is really important in being able to diagnose patients earlier through generating robust models that have trust in the healthcare system with clinicians. This is really important because they have to be able to trust the way, these novel ways that we're going to be helping them diagnose patients with rare diseases. So we also have on the line our technical team, as I say, the commercial teams who've dialed in. So any questions you've got through this session or even afterwards, please feel free to contact us on the chat or via email, and we'll be really happy to respond. So without much more ado, I'm going to turn to the main part of the presentation and we'll speak to you shortly. Thanks.
Welcome back. Here I'm going to talk to you a little bit about why we do what we do and what we discover. This chart represents the delay in diagnosis by population across time, and you can see the red line focuses on where Volv likes to work. So we like to work on the more difficult challenges where the diagnostic time really is delayed. I like this representation of the same data because it shows really how impactful the long diagnostic delay is on a lot of people. When you stretch those timelines out to 20 years, you can see how long it's taking some people to get diagnosed. And the interesting thing that we have found is that when we discover more patients, and i.e. we find that there is a heightened prevalence, it tends to be in the hidden population. And that's important for several reasons. Another challenge that we're looking at is the actual scarcity of the event that we're trying to find. So here is a red dot on the top left-hand side, which represents 1 dot in 400,000 patients. However, a lot of the diseases we deal with have a prevalence that's lower than that, sometimes 1 in a million or less. And if we zoom out to show what that looks like in 1 in a million, you'll see the scale that we have to work at. But that's dots, and we're humans. We're all different, and we need to work with that high degree of variability. For many of the diseases that we've looked at, genomics are not enough of a predictor of the symptomatic outcomes and the quality of life outcomes for patients that we see. As you move from DNA to RNA to the exhibiting of proteins and then the complexity of metabolites, you're getting increasing variability, which is due to internal factors and then more and more due to external factors as you move through this variability chain or cascade. Then you finally get the phenotype. And for one example, rare disease, the predictive gene mutations impacted only between 0.5% and 15% of patients according to literature, which is just such a variable amount that it's almost meaningless statistically. So we focus on the phenotype. So how do we measure this incredible complexity in humans for health outcomes? We use clinicians and we use clinical systems to measure us when we go and visit our doctors, go and get diagnostic tests, have various different types of consultations or treatments. Increasingly, those visits, those interactions, those results are managed electronically, so it's great. We have data now at population scale, which is expected to be used. And this is clean standard data, right? Well, actually, wrong. What we find is that not only is it sparse, gappy, messy, it has what we call label noise, it also has feature noise, But between data sets, between countries, between regions, between systems, you've got data variance, you've got population variance, you've got healthcare system variance. Those are just some of the dimensions. You can add to that languages, so you have to be language agnostic in order to manage all this variability in data without adding the extreme expense of curating it. And the reality is that in many countries, you've got no patients to learn from. This is because of privacy rules. People can't just extract patient records and supply them to you to learn from. So in summary, the challenges we're talking about here are that we're dealing with extremely rare events, which we have to detect, within extremely messy and gappy data. These are highly dimensional problems, but there are no learning labels available for machine learning in many cases. We've talked about the high level and high feature noise, and we've got many different languages to deal with when we move from country to country. But also, not only that, people think about the diseases differently in different countries, we see. And clinical systems are highly variable in both their data constructs, so the data structures, and also in the way that people use those clinical systems. And, you know, people are skeptical that this is at all possible. I mean, given all of that, what possibly could go wrong? How do we start? Well, typically we start with an anonymized data set, around about 3.5 million patients. And I found this picture of a parade in Sao Paulo, which actually represents about 2.5 million people. So you can get an idea of how many people we're scanning and their individual profiles. And that's a lot of people. And typically, remember, we have no labels. So no examples of patients with disease and without disease to learn from. And given a rich health record set, we can use over 10,000 features. You can think of features as unique data points per patient. And for that, using standard AI, you would normally need about 50,000 labels. Remember, we don't have anywhere near 50,000 patients identified with disease. These are rare diseases. We actually have no labeled patients. So that's pretty unique. So how do we start? We start with publicly available data, which we ingest, and we learn these disease models, highly dimensional disease models, which allow us then to perform a feasibility assessment on electronic health records, which tell us whether health records are good enough in terms of quality to allow us to extract the right types of records with the right types of features to learn models. Once that feasibility assessment has been done and we've gated that, we then go on to learn a more complete disease and develop the detection algorithm, which gives us the first empirical prevalence numbers. After that, we validate that through clinical engagement, and we go on to patient segmentation and priority needs assessments if required. A lot of diseases have indications only for a subsection of these rare conditions. And then finally, we move to creating diagnostic tooling, which improves the ability to diagnose the patients in the actual clinical systems in the market. And that novel diagnostic tooling, which has been developed through this new diagnostic logic that we've learned, is given to the healthcare system for free. It's all about results, and on the next pages we're going to talk you through a couple of tables on those results, which, if you bear with me, I'll try and explain as clearly as possible. But these results, while they are hard numbers here, they actually reflect impact on patient lives, so let's not forget that. And then finally, after the results, we'll just round off on some of the other things we deliver from this in order to embed some trust and faith in the algorithms that we build. Now this is where it gets really exciting, because you remember we talked about midway through the Volv process there is a clinician validation, and we have a special scoring method which we have to say we're quite pleased other people are now copying. The scoring is important because it actually allows the clinicians to do a chart review and assess the records in terms of their clinical abilities, which we consider to be gold standard. And then they don't understand or don't see at this point the performance of the Volv algorithm, so they go in blinded with some random examples added in there. So in the top example, that disease is actually acute hepatic porphyrias, and we can see that the algorithm selected a top 20 list and then added 22 people to that list to give 42 patients. And the algorithm, of those 20 patients the algorithm selected, the clinician scored 14 records out of those 20, and 4 records as being possible candidate for that target disease. And then in the next 22, the clinician has added only 3 in the likely classification, but he's added 12 in the possible classification. So the clinician's thinking is actually matching the algorithm's thinking, as it were. It's not really thinking, but it's actually predicting. And that's interesting because it shows that the pattern of matching these records is very similar to the clinical thinking at this stage. Of course, the feedback from the clinician is important because it only improves the algorithm at this stage. And we use some precision K measures, which are the most statistically relevant measures at this point, and you can see that it is extremely high. The grey line, target disease similar list, this is what a more traditional standard query would bring in. So that's what we use for our silver standard labels. So that's how we generate them, the algorithm from that point, that stepping off point. And that's pretty much the performance that most of our competitors will get, is around 28%. So that's quite remarkable. And it's also challenging from a logical point of view, because you can see that from those 50 that we learned from, only 14 came back as plausible candidates, although we have actually in total 33 plausible candidates. So we've learned from imperfect data here. While I think we'll all agree that the performance of the algorithms is really high, what's important is at that point, it's still what's known as a black box algorithm. So no human being with reasonable intelligence is going to be able to understand that model in any shape or form, but it's very performant. So what we've done is we've built a methodology whereby we can take that extremely complex model and develop and create interpretable models from that. So these are what we call clinically interpretable models, so they have low cognitive load for clinicians, and they actually also describe the logic, the high-level logic that the algorithm is doing to come to its decisions. And what this results in is a reprioritization of questions and decisions that clinicians can take to achieve earlier diagnosis. I think in summary, what I wanted to draw your attention to on the last slide is the fact that once we've worked on these extremely performant algorithms, as you may have noted from the actual results and the clinical validation, we've pushed the prevalence rates higher than expected. And these prevalence figures are coming, as we mentioned right at the beginning of the presentation, from hidden populations. And once we've discovered these hidden populations, we can start to map them out and understand them better with the Patient Journey Explorer. And this is another analysis of the data that we perform. And this is extremely insightful because it's empirical evidence showing why these variable lives that are not picked up earlier can be picked up earlier now through learning. And that's a really big difference for patients. So, how can we implement an algorithm that's been derived in this way? Being based in Switzerland, Volv has the opportunity to understand the variability in all the different countries around it within Europe, as well as further afield, and the great variation in the regulatory environments, the appetite for interventions in different countries is very different. Indeed, the healthcare reimbursement models all are very variable, and we get direct insight into that because we're right in the hub of Europe. Just to give a flavour of this variability, we're going to run through just a handful of countries in Europe by way of example of the difference in structural difference in the healthcare systems and why that has an impact on how we can implement, and in fact how we can learn the models. So first of all, if we look at the UK, you've got the NHS, you've got basically a single payer model, but you're actually using read codes which are migrating to SNOMED. If you then look at France, you've got a co-payer arrangement where you have access to claims data, which is different, and you need to link that through to other data sets, and you need to engage with the clinical systems differently because they have disease networks that operate in a different way. If you go to the Netherlands, they have multiple private insurer co-payer reimbursement, but the reimbursement is set at the national level, and they've got a fairly good integrated infrastructure, but they use a different coding mechanism. Again, they use ICPC codes, so you have to modify that. And of course, they're in Dutch. If you go, for example, to Germany, Germany is probably some of the strictest and most difficult working environment for digitization and implementing algorithms. So you have to look at different hospital networks, You have to look at the reimbursement tends to be more uniform, but the hospital networks and data networks and the patient outreach is extremely challenging. So you have to think very creatively around about that. And then when you go to Austria and to Switzerland, they again have a different model once again, whilst reimbursement is good. So you have to think about all these different variabilities. And in fact, one of the key features that we see is that the immigration patterns across Europe actually also have great impact on prevalence of different types of disease. And so we take all of these different types of variability into account. So given all of that variability, how can we implement? How can we actually impact patients? Using the novel diagnostic logic from the models developed, we have to then create novel diagnostic tooling. And because of the variability in the systems, we have to be creative. So we have a few different options available to us depending on the systems. Interpretable models can, of course, just be printed on paper. And that can be very useful, especially if it's difficult to implement electronically or digitally. We can also integrate digitally in clinical systems in some countries at scale, where we have reached to several millions of patients via their GPs. In other countries, we can create red flags for GPs for clinical practice, so they can run the algorithms and they will identify the patients in clinic. We can also do approximate geolocation, not of the patients, but of the clinics and healthcare practices where those patients are being treated, so that interventions can be guided and made in the right places. With partners, we have specialty nurse outreach programs that we can do, and we can integrate into specific digital platforms that are designed to help clinicians diagnose better. Finally, one of the things we're working on right now, we hope to succeed in, is integrating into a model of care in some countries to become the gold standard tool that they use. Remember, each time we do this with any of our customers, we're cutting at the coalface. This is not just simple stuff. You saw the challenges we have with the data, with the systems and everything else, but we have to leverage existing practice, and we create trust relationships in those countries and with those clinicians, and we drive to diagnose patients earlier every time. Because these are real patients whose lives are improved if they are diagnosed earlier.